So my title is Experiences with Web-Based Electronic Systems, but this is mainly in my practice in Leeds and in my research work in Leeds. You can see here our new cancer hospital. This is the outline of my talk. I will focus mainly on how patient-reported outcomes can be used for individual patient care. So this is the impact and potential benefits from a doctor or nurse having information from the patient and implementing it on a one-to-one basis. And I will touch briefly on how that data could be used in the future, but the main focus is really on that individual patient care level. So I'll go very briefly through some definitions and theoretical models, then again very briefly through some systematic reviews and randomized trials showing benefit from this approach, and then a historic overview of our experience in Leeds starting from 1996-97, looking at one trial that we did using quality of life measure in oncology practice, then some work on training, how to engage and motivate clinicians and developing a training session, and then finally I'll finish with current ongoing work of how we monitor side effects using eRapid system and online software. And I'll briefly touch on implementation and give some examples of where we succeeded briefly with implementation. So moving on to the theoretical aspects, when I started doing that work, we were talking about health-related quality of life and not Proms. And I quite liked at that stage that diagram by Wilson and Cleary that shows us like a nice flow between a pathological, a disease variable, which leads to a race of certain symptoms that can be detected and can be measured in a patient. Then these symptoms can have impact on functional status if we move right ways, and this can have impact on whether the person perceives themselves as being ill or not, and how that impacts on their overall quality of life. All of these measures can be influenced by who the person is, the characteristics of the individual, and also where they live and what is their family or social situation. So all of these and other non-medical factors like having a job or not having a job can influence their overall quality of life. But for clinical practice use, we felt that actually a lot of questionnaires measure symptoms and measure impact on functioning. So these parts of the questionnaires we have at the moment would be most useful. And then later that patient-reported outcomes came in, and actually all of these are patient-reported outcomes, but the emphasis from FDA was more or less on symptoms and physical symptoms and some impact on functioning. And I believe that continues to be the main message. It's important to measure physical symptoms, although one could argue with that. And if we have a more formal way of measuring, what we normally assess in clinic as doctors, we ask the patients how they are, we sort of say, yes, the pain has improved or hasn't. If we measure that more formally, maybe that will improve patient-centered care and be the model, the basis for patient-centered care. So this is broadly the theoretical approach of Proms and patient-reported outcomes. Then how could that impact on doctor-patient consultation or nurse-patient consultation? This is the theoretical model which I sort of borrowed from Joan Greenhalgh, who just by chance happens to work in Leeds as well as psychologist in Leeds, which I used many years back during my initial research project. It is a multi-step process. So you start with the patient completing a questionnaire, then these results are given to the clinician prior to patient's visit. Then you expect the clinician to use them in the clinical encounter, because they may not. We sort of assume that if it's there, they will use it, but they don't always. Then you expect that this questionnaire will be helpful, it will detect problems we've missed as clinicians, or it will monitor response to treatment, which is quite important in cancer care. So the first essentially effect we'll see is on the communication exchange over here. And if this is helpful for the particular case, We expect to see changes to patient management, changes to patient behavior, and ultimately better health outcomes, better symptom control, better pain control, and better patient satisfaction. So it's a multi-step process, and when we try to measure the benefits and the outcomes, we have to cover those areas. Usually these here in light blue are known as process of care measures. So when designing a research or implementation project, these have to be looked at. And also you have a more distal outcomes, which are patient-based outcomes, such as improving quality of care or patient satisfaction. There is then a model recommended by Medical Research Council in UK, known as a complex intervention. So this is an intervention which is not just a single drug, so you compare the standard drug with a new drug, but it is, the intervention itself has several components. And in those cases, you have to work out each of those components and put them together in order to see a benefit. So this could be viewed again as a complex intervention. So you have a questionnaire which has to be appropriate and measure what we intend to measure. You have to present the results both to patients and clinicians in a way they understand and make sense for the clinical care. You have to train clinicians how to use that information. And finally, it's quite important to get the healthcare environment and the organization right in order to achieve potential benefit. So this is generally a theoretical framework of using PROs in clinical practice. Then there is this model which Amy Abernethy from the United States introduced first in 2003. At that stage, we had the electronic PROs already more widely spread, and the model is about integrating PROs into clinical care, looking at the individual patient and linking the PROs to other databases on individual patient level. So, and what Amy was claiming at that stage is that by that patient level linking clinical administrative data set will create an environment for us rapidly to learn from our experience. So this is more or less the concept which later became known as a big data concept. So if you put together clinical administrative databases, pathology, tissue banks, and patient-reported outcomes, you get a big data set that could be used to learn very quickly from it. So if you make one change and you have a good system of analyzing that data set and reporting it, potentially you could see a benefit, or you could use that whole system to evaluate your intervention. I don't think we're there yet, but we do have the big data sets. They just don't work as we like them, I think, but that's personal opinion. So this is just another area which is really moving us into more the electronic age, where all of this is possible because we have the electronic data collection. And it also emphasizes the importance of putting that data as part of the electronic health records, which is something we achieved in Leeds. So the evidence, systematic reviews, this is very quick run through. The systematic reviews over here, as you can see, are a little bit old. I tried to update them, and I couldn't easily find another one since 2008, so I'll talk on these. But they do include studies not only in cancer, but predominantly primary care. And all of these are randomized trials that measured the process of care and communication. So this column shows how many studies showed impact on communication, and then how many studies showed impact on patient outcomes. And satisfaction of care were measured in some studies, not in others. So just a quick glance at that shows that most of the studies showed impact on patient communication. That one didn't, but this one was specifically screening for depression in primary care, so it wasn't a broader concept of symptom monitoring and quality of life. But majority of these studies do show impact on doctor-patient communication. Impact on patient outcomes is about a third of studies. So this is the more distal outcome, patient well-being or control of depression in some of these studies. And again, satisfaction with care is patchy, it's on and off. Some studies show satisfaction. And of course, we may be raising patient expectations by using those questionnaires, and that may have impact on satisfaction. Of course, in cancer care, we have slightly different problem where patients are always satisfied, and what we'll show on this. So this slide shows randomized studies in oncology. There are a number, including some more recent, and in these studies, most of them show impact on communication. So if you provide information to doctors that patients have completed before consultation, usually you see impact, doctors discuss more issues. Decision-making column is about changing medications, changing patient management, and that is not detectable in any of those studies, apart from a very recent study by Ethan Bash using online monitoring, where a smaller number of emergency room visits were noticed in the patients who did the online intervention. And in terms of patient well-being, not many impacts. Our study in Leeds, the study I ran in Leeds, did show impact on patient well-being, and I'll talk about this in a minute, and no effect on satisfaction with care, mainly because we see a ceiling effect. All patients are satisfied, so you can't really improve from that. So we need different questionnaires, and I tried with different things, doesn't quite work, so that's probably not a good concept for oncology, I think. Okay, so moving on to our experience in Leeds. We're celebrating 20 years since we started that work this year. So that's quite frightening. And the frightening thing is, if you asked me 10 years ago, I said, yes, by 20 years we'll be using it in hospital. Well, we're not yet. Better than 20 years ago, but not yet. That's why I came here to learn from you. So the first study it's now old, published in 2004, but it was the first randomized trial that showed patient benefit. And that's one point I want to make. It did have impact because of that. Now, maybe we were lucky, I'll say we. I think it was possibly because we paid a lot of attention on how to develop the intervention. It was my PhD project, so all of my colleagues really bought into it and were curious what will happen and how it will work. So they really supported me. So I think that's what made the difference. At that stage, we used touchscreen computers, as you can see on this slide, which patients completed before seeing a doctor in the outpatient clinic, and a printout of the results was produced immediately. Very low tech. It was Access database basically with Excel doing the printouts immediately, so it wasn't integrated with anything standalone program. But it sort of did the function. And this is what we showed the doctors in the printout. QLQC 30 was the main questionnaire, although we used hospital anxiety and depression scale as well. And it showed results over time. So this is fatigue. A patient started with a lot of fatigue, which gradually improved. That's a lymphoma patients having chemotherapy, so they did get better, as we would expect. And one way doctors dealt with that information, I trained them briefly in the beginning, telling them how to interpret the results and how to match it to the clinical data sets. And they looked at the symptoms first and said, okay, there's a lot of fatigue. How is that impacting on function? Okay, they're not moving very much, these patients. They don't work. It has impact on their own function. So this is the way the doctors used these results, following very brief training, essentially, just showing them the questionnaires and some examples of cases. And this is what we've shown. We've shown that we randomized the patients into 3 groups. So patients who completed QLQC 30 on touch screens, and we provided the information to the doctor, so that was our intervention. Then we had a usual care group where patients didn't do any touchscreen questionnaires. And then we had a attention control group where patients did the questionnaires, but we didn't give them to the doctors in clinic. So that was the attention control, with the hypothesis that maybe the questionnaires will prompt patients to actually discuss the issues with the doctor. And then we had FACT-G, another quality of life questionnaire, which was our outcome measure, done on paper just to separate it from the intervention in case the patient gets used to completing questionnaires in the intervention group. And this slide shows changes over time of FACT-G. So it is the change score, not the actual score, and it shows that patients in the intervention group improved over time, particularly at 3 months measurement, more than the usual care group, which is that one here. And the patients in the attention control group were kind of in the middle, but the biggest difference was here between the intervention and usual care group. The curves go together afterwards. Quite a bit of attrition rate, I think that probably explains it. And that was a group of patients with advanced cancer, so you don't expect them to improve improve hugely over time, but that was probably effect of attrition. So we had attrition rate at that point, up to 3 months after starting chemotherapy, was in the order of 20%, 25%, which is expected. So one important point about this study is we did show that potential benefit for patients, which gave some credibility to this type of intervention. Then the other point I wanted to make about it is we spent lots of time looking at actually what happens in the black box once, or behind the door, once the patient goes in to talk to their doctor. So we recorded consultations, about 1,600, something like that, and we did content analysis. We listened to 860 consultations per patient. So baseline, and then first, second, third consultation on study. And we looked at what symptoms were discussed, what functional issues were discussed, and who started them. So very basic content analysis, because we had to choose either between a very complex, in-depth consultation analysis of communication, or something which is quick and dirty, but actually we can cover lots of consultations. So we did the quick method. And what this showed is that when we provided quality of life data, we observed more discussion of non-cancer specific symptoms. I would say insomnia and dyspnea were the significant ones. If you look at the graph here, these are the three groups: intervention, attention, control, and control. And this is the proportion of consultations in which that issue was mentioned, so insomnia in that example. So at baseline, no particular difference, about quarter, 25% of the consultations, this was discussed. Then the first time quality of life information was provided, there was an increase in the discussion, 38-40% in the intervention group, a bit of increase in attention control, and about the same in the control group, the usual care group. So we are seeing an effect. The biggest effect is the first time that information is provided, but in that case it persists over time. Physical function, emotional function also have an effect. This is an example of a physical function here, where at baseline it's about a quarter, 30%, whereas there's an increase. But interestingly, the increase here is both for intervention and attention control group. And when we looked at who started these discussions, symptoms were usually started by the doctor, whereas the functions were started by patient or relative. So there was a bit of a difference, which probably explains the attention control group increase here. So we're beginning to understand how doctors are using it, and that it does have some impact. And one of my PhD students did another study based on that data, looking at whether there is a correlation between the severity of the reported problem by the patient and the frequency with which it was discussed. I'll explain these graphs because they're complex. So these are patients split by no problems reported to severe problems reported, and these are the different symptoms in different colors. So what this is showing is that if patients reported severe symptoms, in majority of the consultations, up to 100% in pain, that issue was discussed. This is the sleep, for example, the lower line, about 70% sleep was discussed if it was reported by patient as being severe. And as you would expect, if the patients didn't report a problem, it was still mentioned because we are trained to ask about pain and sickness in oncology. But there is a trend here, as you would expect. If you look at functions, though, there isn't a trend. Basically, they're all over the place. So the message here was that as doctors we're trained to talk about symptoms, but we're not so confident covering the functions, and maybe even severe problems with physical or emotional function will be missed because only half of those consultations these are discussed. So we concluded from that perhaps we have to find ways to increase the impact of that information that is provided to the clinicians in order to increase patient benefit. Okay, so that's where we moved more towards developing a better training program from just informing clinicians. So this is my next brief study I'm going to present to you, which is looking at how to train clinicians to use patient-reported outcomes. This is a recent publication which we did together with Maria Santana and Lotte Haverman. Maria is in Canada and Lotte is in the Netherlands. And we compared the training programs we used in studies in quite different settings. So mine was in advanced cancer, Lotte did pediatric oncology, and Maria did lung transplant. And actually there are a lot of common elements across these programs. And we decided that there's benefit of actually publishing that together. So if people are interested, this is worth looking at, just comparing what people did in terms of training. But for our program, we started with a theoretical framework looking at how to change medical practice. This is difficult, we know it's difficult. I quite like that publication by Richard Grove from the Netherlands, who recommends a combination of approaches. So there is an education element, theories of adult learning. You have to present evidence-based and systematic reviews and evidence of benefit. You also have to pay attention to the needs of the target audience. So say, look, this will help you, it will speed your consultation, etc. And also ask the doctors and the nurses what they need, how they want to see it, when they want to do it, etc. And then once you start, behavioral element of feeding back and how they're performing is helpful to include as well. And of course, social interactions using opinion leaders, etc. And how you change the organization to adopt these is question. We haven't cracked those, and I think Liv probably talked about these things, although I couldn't get all of it. So I wouldn't spend more time. But what we did on a practical level is we designed a training session which we wanted to be brief, sort of 2 to 3 hours maximum, to be able to fit it in busy practices. And the structure and the content was based on feedback that we received from oncologists from previous studies, and on a national communication skills program for oncologists, which was running in UK at the moment, based on experiential learning. In that program, there was a lot of role play, so actors were present, and it was running over 2 or 3 days. And it was good fun, but 3 days, and we couldn't do 3 days, obviously. So we thought we'll get elements from that, but develop like the trigger tapes, we called them. So this is brief scenarios, brief video programs, showing how doctors are using it. So this is our prior qualitative studies on which we based some of the key messages in the training. Joan Greenhouse did conversation analysis of the consultation, which is quite an in-depth analysis of a selected number of consultations. And we found that explicit referral to the PRO data during the consultation is important, because often the doctors will look at it and they say they used it, but if you ask the patient, they said no, they didn't actually. And that's not giving good message to the patient. So it's actually quite simple. We went through all of that research, ending up with, please use it, please say thank you to the patient that you did it for us. I see you have a problem here, tell me more. So it's actually very simple how you train doctors. When we interviewed my colleagues, they wanted more training in interpretation and use and actions, and they wanted cancer-specific questions relevant to their practice, which we did for them. Anyway, so when we developed the trigger tapes, we used common and typical clinical scenarios, so we wanted it to be real life. So we selected 4 types of scenarios. We had patients with multiple physical problems and emotional distress, which is the patient each one of us sort of thinks. Heart-sink patient, we call that in English. I don't know what that translates, but when you see that patient, you say, okay, that will take a long time, I'll better prepare. So it's that kind of a problem we got. And of course, people say, what if they have many problems and I can't address them all? What do I do? So that's one of the big barriers. So we had one of those scenarios with the key message being, it helps you to prioritize and actually structure the consultation and maybe deal with the urgent ones and then deal with the others at the next one. We had a patient with depression, how to manage, how to diagnose it. Patient with physical symptoms, limiting work and family, so some social problems here, with an example how to detect those problems and refer on. And then patient responding to treatment who is doing well, where actually it saves you time when you know that. And we video recorded those using the university established system for medical education. We worked with the medical education unit. 5 of my colleagues, oncologists, agreed to do them. And they weren't scripted. We provided them with a scenario, and we provided a separate scenario for patients who they weren't actors, but they were former patients or carers who were helping during the medical exams where there is a role play in scenarios. So they knew how to handle different scenarios and how to provide feedback afterwards. So it was great fun actually doing that. I really enjoyed that. So we recorded these and then used them in the training session. The training session was up to 2 hours with a break. We did have the education, didactic overview of the evidence. We discussed with the doctors some of the PRO graphs. And then we went on to the interactive session, providing clinical information initially, showing PRO data to the actual doctors who participated in the session, and then going through the DVD clips and discussing how the data was used. Will the doctors who were trained use it differently? And then we reviewed the feedback from patient after on the value of that data. This is one example. I just put it as a, I know you can't read it, but it's the clinical summary. Then the doctors review the patient profile, and this is the functional scales of C30. These are the symptoms, so patient with multiple symptoms basically, and quite severe impairment of functions. You don't often see such severe functional impairment. And the example was how to prioritize and structure the consultation and deal with these multiple problems. We now have these video clips on YouTube, but they're sort of protected and we still haven't decided how to use them. I'll skip that slide. Then we did a small pilot study to evaluate that training session. It was a simple before-after design. We used 3 oncologists and 10 of their patients before the training. We provided the information and only trained the doctors how to interpret the results and what the questionnaires were. And we recorded those consultations. Then we had the training session and did the same with another 10 patients per doctor. These are preliminary results. We're still finalizing the analysis. When the questionnaire was explicitly referred more in the consultations after the training, so 48% versus 77%. So there was an effect of saying, please use it. That's the bottom line. The mean number of discussed symptoms did not differ, so the patients didn't have the symptom, they didn't discuss it. Probably we should have expected the difference here, but it's not powered to detect big differences. It's just to see if there is any trend. There was a slightly more discussion of functions after the training. Specifically, physical function was discussed a bit more, 87% versus 61%, and interestingly, pain as well. My hypothesis wouldn't have been that pain will be different. I think we all discussed pain with our patients, but maybe I was wrong. So then just another example of, for emotional distress, we provided some guidelines how to refer on and who to refer to. And we work in our practice, we broadly know what the referral pathway is, but we have lots of junior, well not junior, but sort of middle grade doctors who come training for 6 months and they don't know that information. So I thought if we have information provided, that may help them to action the results they're seeing and overcome that barrier. So what we observed is if patients had severe emotional distress, so the last 25% top quartile, and we had 19 of those patients, the emotional distress was raised in 70% of the consultations, predominantly initiated by doctors, and 5 referrals were done to the psycho-oncology department and 1 prescription of anti-anxiety drug. If the patients had moderate depression, the emotional distress was raised in smaller number, and there were no actions or referrals, and if they didn't have any problems, it was still raised in some consultations, but mainly by the patients, not by the doctor, and complementary therapy was recommended. So you could see a trend and you could see potential benefit in the more severe end of depression, screening for it, and then doing some actions with the support of our guidelines. So what we've learned is that worked examples and scenarios were great. Actually, we had great time discussing how our colleagues do things, but it is time consuming. And we're now looking at more focused training and support. E-learning programs are increasingly coming. They're not as good, I think, but probably is the way forward, and that's what we're looking to do now. And what we need to provide to our colleagues in order to use it is how to access the data, where to find it, how to interpret the graphs. Main message, please refer explicitly, mention it to patients, thank it. Invite them to explain a little bit more where there is a problem, and then discuss and act. And specific guidelines and referral pathways are helpful as well. Okay, so that's on the training. Then moving on to what we do now in monitoring side effects. So this is based on patient-level linkage. So we did a program of research which is funded by National Institute for Health Research in the UK. So this is the main funder of health research. Over 5 years, then we had another 1.5 year developmental project before that to develop and evaluate that system, and I'll take you through it. Basically, it allows patients from home, very similar to Ambuflex, or from clinic, to complete questionnaires. The questionnaires are completed by a software program called Q-Tool, which is it's a standalone program. It's hosted on university servers at the moment, but it can be hosted anyway. It's outgoing, so patients can log in. Then the data which goes into the university service is basically anonymized. So patients are given username and password, so it can be identified. Their identity cannot be seen from there. And then the trick we did for that program is how then we identify who the patients are beyond the NHS firewall. So this is the hospital NHS system in UK, which is protected behind a firewall. And we wanted to display these results into the electronic records. So they're here, the electronic records, for each individual patient in real time. And what we did is I appointed an IT programmer who created that additional piece of software which basically provides the linkage between the electronic record and the name of the patient and their username and password. And then it pulls the results within 2 or 3 minutes of completion and displays them into the electronic records. So then the hospital team, doctors and nurses, can open the electronic records and see the results of that patient displayed in there, or ask the system, pull please the latest results, and they will see it without logging into a separate system. I wanted to avoid using a separate system, but actually integrating it, because when I go to clinic, I log into, I don't know, about 6 or 7 different systems: the main computer, electronic records, the digital dictation software, the chemotherapy prescribing software, and one more is the ordering of investigation. So, and I thought, if I say login into that one, there's no way they're going to do it. So we wanted it to be displayed in the electronic records, and we achieved that. So we're currently using the system in a program called eRapid, monitoring adverse events and toxicity during cancer treatment. And then I'll give you an example of our first implementation project, using it for holistic needs assessment by nurses, and I'll mention it in the project. So this is our eRapid program. We use a website which allows patients to log in from here, and also provide some information on how to manage side effects of cancer chemotherapy and who to contact for emotional support, etc. So if patients click on here, that takes them to the website for the questionnaire. The software is called Q-Tool, that's why you see Q-Tool. They log in, I don't show you all the screens. They log in with their username and password, and they get into the questionnaire, and you can put more questionnaires with time windows on them. So we are using CTCAE criteria, but changed into patient language in order to preserve the grading of severity. So this is an example of pain, no pain, mild pain, so this is grade 1, moderate pain, which interferes with function, this is grade 2, and severe pain, not able to do simple things, which is grade 3. And we wanted to use that so that we can provide advice to patients. The algorithm behind provides advice for mild, for grade 1 or 2 symptoms and toxicity, and provides alerts to patients and to doctors for severe toxicity. So this is an example. If patients say, I had severe pain and I can't dress myself, then immediately the system will tell them, please contact the hospital, and it will give them contact number and everything. This is just a demo here. And an alert will be generated that will be displayed in the electronic records and also sent by email to a key worker, which is usually a nurse specialist for that patient. This is an example. If they have a mild pain, the algorithm behind will provide some advice on how to manage that pain. And also, the advice is quite brief because we were limited by the amount of text we can put in. But then it provides links to the website where patients can read a little bit more about the specific problem and how they can manage this. So basically, this is what the system is. We're currently, this is what the clinicians see in the electronic health record. So there is a tab in their record, in each patient record, which says Q-Tool or eRapid, and they click on that tab and it shows the results. These are the separate toxicities. That patient didn't have temperature or diarrhea or constipation, but they had nausea and sore mouth, mucositis. The red triangles are the chemotherapy cycles, so the system pulls it from the electronic record and displays, because that's what the doctors wanted to see, how it relates to the chemotherapy. And we have it in a graphic format like that, and we have it in a tabular format, which you can't see very well, but the severe symptoms are highlighted in red. And also, if there are alerts, they are displayed on the top, and the doctors or the nurses can provide a response to the alert and say I dealt with it, so don't pay attention to it. As you can see, they're not quite as nice as Ambuflex, the graphs. And we were looking at better ones, but we were restricted because it's displayed in the electronic records and they were developed 15 years ago. We were restricted essentially by the programming of those, but certainly they can be made looking better. So now we're evaluating this during chemotherapy in a randomized trial. So this is our patient selection here. And patients who agree to participate use their own computer at home, or tablet computers, most of them, or laptops. And they're randomized to do the intervention and complete. We're asking them to complete weekly the toxicity reporting, and we're sending them reminders to do that. And the usual care don't do the monitoring. And we're measuring patient quality of life, basically. We're using FACT-G, but we're also doing quite a detailed cost-effectiveness analysis of this, looking at supportive medications, any other expenses patients may have, the costs of the intervention, etc. So we've done internal pilot, just completed it, and we're about to start a randomized trial. And it shows it's feasible. We recruited 87 patients over 6 months. This is showing the recruitment graph. This is our predicted. And this is what we did, so almost as we predicted. We had 80% consent rate of patients agreeing to participate, and our prediction was 60%. So our stop or go rules from the pilot into the randomized trial were 60% consent rate and 30% attrition rate, and we actually did a lot better than that. We had 15% attrition rate, and most of that was due to patients actually stopping chemotherapy rather than explicitly saying we don't want to do that anymore. That was relatively small, only 6%. We're yet to analyze how compliant patients were with the weekly completions. And we are monitoring that as we go along, but we haven't formally analyzed it. And we had a few that didn't do it, but the majority did it most of the time as expected. Okay, so I'm coming to the end, 5 minutes. So that's all good, but this is all research, and we supported research funding. Our first attempt to do service development project and to actually use our system routinely was to do holistic needs assessment with nurses. This is a requirement, or has been a requirement for some time in the UK. Every patient with cancer needs that holistic assessment at the time of their diagnosis and at critical points afterwards. The stress thermometer is recommended, but actually it's not really happening. In some places, nurses do it on 30 pages, quite long document, and that's clearly not feasible in daily practice. In others, they don't do it at all. And we wanted to see if we can use that system to help them. And we had a very keen, nice clinical nurse specialist in prostate cancer who said, yes, I'll do it. I'm using the stress thermometer on paper. I'm quite keen to try this. So we started running this service project essentially with her. This is what patients complete on Q-Tool. You have the distress thermometer here, and then you have a tick box of various problems, practical and family problems on this slide. And then this is the display in the electronic records for the nurse, the score on distress thermometer, and whether patients selected any of the problems and how they rank them. There's a question ranking which is the most important problem. So for this particular patient, they ranked practical insurance problems as their big issue, and then work problems as well. So clearly a younger prostate cancer patient here. And then we recruited 136 patients who approached, 88 of them completed it. And importantly, that was done not by researchers, but it was done via the usual recruitment clinic letters. So we trained the administrator of the clinic to add additional letter with information for patients, send it before their appointment, and then asking them to complete before they come to clinic. Now, majority of these completed it in clinics as well, because we provided touchscreen computers in clinic for them to complete. So that was kind of working. We were providing some support, but it worked over 8 months, and then that nurse left, and the other one didn't want to do it, so that's where we are at the moment. This example of reporting of emotional problems, the kind of data you get out of it, that most patients had fear and anxiety and fear of recurrence, over fear. Now we're running another project at the moment. One of my consultant colleagues, Dan Stark, is doing follow-up of testicular cancer patients remotely. And I think this is, although my interest is more during chemotherapy, but I think really the follow-up is where the big opportunity is for the electronic assessments. So again, an administrator is running this. She's sending letters to the patients, and there is a separate scheduling program for the different pathways, how frequently these patients need to complete their quality of life question or their symptoms, and then go to the GP, have a blood test, and have their X-ray done. And then my colleague is checking these results on a regular basis and calling patients back if need to. Testicular cancer is a good model because it has a good tumor marker which can detect relapse, and a good established pathways of frequency of follow-up. So we are monitoring this. We've just appointed somebody to evaluate what are the benefits of this program. Yes, I've seen it finishing. So implementation, apart to say we somehow failed so far, and I want to learn from you, not much else, but as I said, I'll talk about it. I did look what is available in the literature, and I know a few people who are doing it, internationally in Europe and in the United States and Canada. And 33 systems were described by this review of electronic patient-reported outcome systems. They were treatment-centered, monitoring treatment like in our ERAPID project, or patient-centered mainly for follow-up, or supporting patient-centered care. Integration with electronic health records is on the agenda, and quite a few people are doing it. So things are happening. But I bet our system is in here, and I wouldn't say it's routinely implemented. Then I was very impressed by AmbuFlex, and I did that before reading the agenda for today in Danish. I listened to a very nice presentation, I think by the main author here, Liv, at ISOQOL conference, and I was really very impressed by the system and how it's implemented. So I thought I'll just give you that example, that you do have a good system and it's worth working on wider implementation. And then another one that I know about, which is probably one of the oldest, is in Canada, in Ontario province in Canada. For many years, maybe about 20 years, they have kiosks in clinic where they collect symptom assessment. They call it ISAC tool. And they use Edmonton Symptom Assessment Scale and a number of other questionnaires. And they have got something like 30,000 patients doing it for a lot of years, and providing that information to clinicians. And I was quite interested, and sort of they unexpectedly approached me about 6 months ago, or maybe longer, saying, well, we haven't trained our clinicians how to use it. Can we talk and see how we can do that? So they're still trying to improve the system. But it is implemented because it's sort of centrally organized for the province, and it works. And I think that's the same group of people are running like a project to evaluate it and implement it more widely. They have quite a big, quite an interesting website, so it's worth looking at, with examples of clinicians using it, examples of DVD. So the whole toolkit is there, examples of the questionnaires and how they're scored. So if I understand correctly, that's kind of communication strategy that we probably plan to do in here as well. So in UK, I'm not involved in the UK-wide Proms initiative, which is implementing and using patient-reported outcomes for, they started with routine surgical procedures, hip replacement, knee replacement. Because it is separated, it's paper-based, and it's only about outcomes, none of this data goes back to individual clinicians. So I can't talk on that, so sorry if I misled you, but I don't think it will be right for me to do that. So this is just how to increase the impact. I think the online reporting, the integration of electronic health records is important, training is important, health economics cost effectiveness is very important to demonstrate so that we have a buy-in from the National Health Service in the UK. Also integrating the whole system perspective, integrated care pathways and how we design referral pathways based on the patient self-reports, and organizational changes using champions in our organizations is obviously quite important, and using online toolkits. And that's it.